I'm over here quite a bit. So if you break it down by the week, Sunday is always kind of what I consider the first day of the week. It's the day after the game. So we evaluate everybody's injuries that we remember from the game or something that just popped up overnight. So that's Sunday. Monday is usually a rest day for the athletes, so there's not too much action to do then. I always have a clinic on Tuesdays and Thursdays, and then the rest of the week I'm pretty much on call for the athletic trainers whenever they need me to come over and take a look.
Specifically as it relates to the football team, if there's a serious knee injury, serious orthopedic injury, you would be the one to do that surgery?
I am. So I'm fortunate enough to have the opportunity to see the injury acutely. You know, as an orthopedic surgeon, that's something that we're not very used to in the clinic setting, is actually seeing someone injure their knee or their hip or their shoulder immediately at the time of the injury. So being on the field and being on the sideline gives us the opportunity to see a patient or an athlete right when their injury happens, which is, that exam is probably the most crucial exam that we can ever find.
Why is it so crucial when you're right on the spot and can make that an immediate diagnosis?
Well, not only do we have the opportunity to actually see the injury happen, but once the injury happens, the patient at that point doesn't have much swelling in the knee. They obviously have pain from the injury, but they haven't developed some of the other pains from the muscles or the tendons around the knee that often happen after a couple of days. So usually patients are able to relax and you get a very good evaluation of the joint. For instance, the knee is loose, it's able to be evaluated. So if you're trying to diagnose an anterior cruciate ligament tear, the patient's knee is usually relaxed enough where you can get a very good exam, even better than 2 days later.
Because knee injuries are so prevalent in football, perhaps now is a good time for Dr. Ross to look inside the knee and explain the various ligaments.
So surrounding the knee are two collateral ligaments. You have the medial collateral ligament, which is on the inside part of the knee. That's called the MCL. Whereas on the outer part of the knee, it's called the lateral collateral ligament, or LCL. And those are responsible for providing stability to kind of varus and valgus, so stressing the knee in and out like that. Now, if we look at the inside of the knee, this is where the two crossing ligaments, or cruciate ligaments, are found. The one in the back of the knee is called the posterior cruciate ligament, or PCL, whereas the one in the front of the knee, which we always hear about athletes tearing and having surgery, is the anterior cruciate ligament, or ACL.
Now, you do, generally speaking, wait a couple of days to do the surgery so the swelling will go down, that eventual swelling will go down?
Specifically with regards to ACL surgeries, we definitely do wait. Multiple reasons. So we like the patients to have full range of motion of their knee before they undergo a large ligament surgery such as an ACL. Because what we found is that if we try to operate on athletes too quickly before they've gained their full range of motion, there's a high percentage of time after surgery that they'll actually lose range of motion that may be permanent. So it's not uncommon for us to wait 3 to 4 weeks to wait to do an ACL surgery.
Of course, in the last couple of decades, we've had the onset of arthroscopic surgery for certain procedures. And that's certainly less invasive than traditional surgery. Is that more done for meniscus rather than ligament type injuries?
An arthroscopy alone can usually be done for meniscus treatment. Sometimes we have to make an incision to assist with perhaps a meniscus repair where we're putting sutures in. But ligament surgery usually will always require an open incision. Most commonly in athletes to harvest a graft to replace the ACL. But the surgery itself is arthroscopically assisted, so the arthroscopy portion of the case is extremely important when looking at the anatomy and trying to place that ligament perfectly where it should be.
You do numerous surgeries per week, I would imagine. I don't know if they ever become routine when you're going inside the human body, but is the attitude for each patient, this is something unique to them?
The way I think of a patient is their joint is almost like a fingerprint. It's very unique. Not everybody's anatomy is exactly the same. So I rely a lot on planning for surgery. I try not to just say, okay, this is an ACL surgery, let's just do it like the rest of them. I spend a lot of time looking at x-rays, MRIs, as well as relying a lot on their physical exam, because there's subtle things that you can see on physical exam that's different from patient to patient that dictates how you just tweak the surgery just a little bit.
Is the big reward for you seeing somebody who you performed an operation on, repaired a ligament, a joint, anything, seeing them back out on the playing field and performing, does that give you a sense of satisfaction?
Absolutely. You know, the athlete is the best patient. They want to do their therapy. They're motivated to get back. In my mind, that's the best patient to have, and to see them and actually experience them get back on the field, although at the first time when they're back to play, I'll tell you, it's a little nervous, not only for myself but the patients. But once you see them, you know, catch a ball or score a touchdown, I mean, to see the excitement on their face, knowing that they've gone through all those months or potentially lost a season because of their injury, and see the excitement that it brings them, you know, there's nothing better.